Good evening. How's everyone doing? Good. First off, I want to say that this is your third meeting, right?
Yeah.
You're already doing the right thing because you have youth in the room. So, good job there.
Thank you, Mr.
I want to applaud you all.
Thank you.
Don't ever underestimate the role that you guys can have, that you all can have in this process. You are the voice that needs to be heard, so I'm so thrilled that you're here. So thank you for taking time away from your evening, and a special kudos to your teacher for seeing this opportunity, not just giving you the professional experience around it, but realizing that your voice is powerful. So thank you all for being here. I want to share a little bit of my background and my story, but first I want to, now that we have the internet working, I want to share a couple films from one of the programs that's under the umbrella of Each Mind Matters. I'll give you a little bit of context in general though. So through MHSA funding, Napa contributes to what's called CalMesa, the California Mental Health Services Authority. And through CalMesa, basically the idea was that it just simply made sense for counties to consolidate their funds on a few projects. Number one was a social marketing effort, which became Each Mind Matters and Other Signs, and I'll give you more of an understanding of what those two entities are. But one example of that would be, rather than each county individually creating suicide prevention posters, mental health brochures, and trying to reach target audiences, it just made sense for them to pull their money and create, rather than just each county having an English and a Spanish poster, we have materials in English, Spanish, Tagalog, Korean, Mandarin, just a variety of languages. And through that, one of the programs that came out of it is the Directing Change program, which is a high school and youth and young adult mental health and suicide prevention program. And it's centered around a film program or a film contest, but it is so much more than that. It is a mental health and suicide prevention program. But rather than going into a classroom and talking to youth for an hour about mental health and suicide prevention, it invites youth and young adults to create 60-second films about mental health and suicide prevention. So I wanted to share a couple of the films from that program just to kind of set the tone for the day. My secret agenda is that the psychology class students are going to want to participate because the deadline is March 1st, so on it. All right, so I'm going to share, these films are just 60 seconds and hopefully everything works.
Studies show that 1 in 5 teens are living with a mental health challenge.
However, mental health symptoms are treatable.
Don't be afraid to take a stand against the stigma.
Speak up or show support.
If we all speak loud enough, we can end the silence for good. Join the conversation and find support at www.reachouthere.com.
This was the first day we met. I knew right away that you were going to be a big part of my life. We had so many good times. But this was the day you started acting different. You isolated yourself. You were sad all the time. I thought you were ignoring me. But when I saw your wrists, I knew it was much more than that. I knew I had to talk to an adult, so you could get the help that you needed. And today is the day we appreciate the life that could have been lost.
Not every friendship has a tomorrow. If someone you know is showing signs of suicide, talk to an adult or call the suicide prevention lifeline, because suicide can be prevented.
So those are just a couple films from the program, and actually while I'm on the website, I want to show you how you can also access these films. So the website is Directing Change or directingchangeca.org. When you come to the home page, it is going to look like this. It's going to look like that. This is where you can get all the information about participating. But right here at the top, Watch and Use Films, when you click on that, we have a registry of films. We're in our 6th year of the program now, so we have films from each year, and you can identify by category. One of the things I really like that we've done is films for diverse communities. So we have a category called Through the Lens of Culture, and that category requires films to be made about mental health or suicide prevention, but that focus on culture. And culture, we give a very loose definition of it. It could be a more defined culture like Latino or LGBTQ culture, but it could also be nerd culture, jock culture. It doesn't have to be just, it also doesn't have to be just one culture. You know, we may not realize it, but sometimes we identify with different cultures depending on the hour of the day, whether we're at work or we're at school or whether we're with our families. And when you go to this tab, it will give you just a brief one-sentence description about the film. All these films also have English captions or subtitles so that they can be shared with the deaf and hard of hearing community as well. So I just wanted to share that resource with you. But it sounds like you're already familiar with the program? Excellent.
I think New Tech High had a submission a few years ago that...
Yeah.
Okay.
Yeah.
Great. Excellent.
Was it finalist?
Yeah, I think they were finalists, yeah.
Okay. Yeah, and then I'm trying to think. No, that was the last film was from Sonoma, not Napa. The New Tomorrow. So I'll give you a little bit about my background. So I've worked in suicide prevention now for about 17 years. In that time, I've provided training to about 750,000 people. In 2001, I testified before the United States Senate specifically on youth suicide. So a lot of my focus has been around youth suicide, but I work with the Each One Matters campaign. I also work independently with counties as well. And a lot of my key focuses right now, outside of the work that I just kind of mentioned with Directing Change and Each One Matters, but through Each One Matters, is helping counties create suicide prevention strategic plans, create this entity, this guiding entity, because the California State Strategic Plan that was created in 2008 called on every county in California to create a strategic plan. You are now becoming the 7th out of, 58 counties in California to actually have a strategic plan 10 years later. So that is good news for Napa, but it shows a sign that we are still a long way. We have a lot of catching up to do throughout the state of California. The other effort that I've been highly engaged in is what you were mentioning earlier, AB 2246. I was part of the California Department of Education's team that created the model policy for districts. And through Directing Change, really when we created the Directing Change program, when I got asked to be a part of it, they were just hoping to maybe get 50 to 100 films from around the state. It was going to be a one-year program. And when they hired me onto it, it was me and Yana who created the program. I said, look, I don't want this to just be a film contest. If we're going to do this, we're going to do it right. And we're going to use this opportunity to have conversations with schools about suicide prevention. Because working in school-based suicide prevention, the most frustrating thing to me was that schools often didn't want to engage in suicide prevention until after suicide had happened. That's when I got the phone calls. Hey, can you come in and present to our staff, present to our students? And I wanted to use the Directing Change program as a way in the front door to open up the back door to prevention policies. And so Assembly Bill 2246 requires all schools and districts that serve pupils in grades 7 through 12 to implement suicide prevention policies. And the reality, though, was we created this model policy with CDE, but there was nobody there to help support the districts and the schools. And so we're going to have a meeting at the end of the month. We'll be hosting a training here in Napa on March 15th as part of a student wellness conference. It's going to be an 8-hour training. And this will be about the 20th training that we've done around the state to really sit down. It's a kind of an adult-style learning where it's presentation mixed with group discussion, mixed with in-group work to get schools to understand what is truly meant by comprehensive suicide prevention. So that's a little bit about my background. Another portion of my background is I spent 5 years as a lifeguard and an EMT with the San Diego Fire Rescue Department. But the most important part of my background is the reason why I do this work. I've been engaged in this work ever since in my entire adult life, honestly before I was an adult. And the reason why I got involved in this work is that I'm from San Diego, I grew up in San Diego, and growing up, my older brother was best friends with a guy named Casey, and his younger brother named Jesse. And so whenever our older brothers would go to movies or go to the beach or go somewhere, our parents, our moms would always make us tag along, and they'd say, hey, you kids, you go along and stay with your brothers. And me and Jesse were very different people. Honestly, I was probably 100 pounds dripping wet my freshman year in high school. I was a self-proclaimed nerd. Comic-Con's cool now. When I used to go to Comic-Con, it was not cool at all. It was 100 nerds in a room, and we were trying to, if you had issue 112 and 114, you were looking for issue 113, so that's kind of where I was. And Jesse was on the other end of the spectrum. He was cool, a kind of tough guy, ran with the rough crowd, and so I just idolized him. And Jesse was a year older than me, so even more so, I thought he had the whole world figured out. And I kind of think of mine and Jesse's relationship that I was probably like the little puppy dog that just kept coming, and Jesse would push me away, and I'd come back, and he'd push me away, and finally he's like, all right, I guess you could stay. And so going into my freshman year in high school, I was lucky because one of my best friends was a sophomore. Jesse was a year older than me, and so I could go to him with my questions, where to get my locker, which teachers, which classes to take. And I was really lucky because we ended up in the same fourth period geometry class together. And so every day I knew that if I could survive periods 1 through 3 and get to fourth period, that one of my best friends was going to be there. From there it was lunch, a couple more hours, and everything was going to be fine. And I went through those days, except for one day I came home from practice and I was walking down the hallway of my house, and my older brother was coming towards me. And my older brother's 4 years older than me, so at this point he was already in college. And my older brother's a San Diego Police Department officer. And me and him are on very different ends of the emotional spectrum. And so this is one of 2 times in my life that I'd ever seen my brother cry. And so the second that I saw tears in his eyes, I knew something bad had happened. And so I went up to him and I asked him what was going on. And I'll never forget what my brother said and how my brother said it when he told me that Jesse had died by suicide. Because I was a 14-year-old boy. I'd never dealt with, really honestly, with death before, let alone the death of one of my friends, and especially to something like suicide. And I remember just getting the news from my brother and just stepping back until I hit the wall and just sliding down and collapsing and just crying for hours. And for those of you in the room who've lost someone to suicide, you know it's every emotion. It's anger, guilt, confusion, shame, just it all comes down at once. And the next day I went back to school, and I think part of me wanted to go back to school because I still didn't want to believe that this was real. And I wanted to walk into that fourth period class and I wanted to see Jesse and think this was all a bad dream. But instead, that day and every day for the rest of the year, me and Jesse had our desks right next to each other so we could hang out. And so every day for the rest of the year, I sat next to his empty desk. And every day I sat there and I wondered what I could have done, what I could have said. I thought me and Jesse were close, but why didn't I create that space for him? Why didn't he come talk to me? I had a lot of anger at him. Why didn't he come talk to me? And after a while, it turned to guilt and shame. Why didn't I go to him? Because even though I wasn't educated about mental health or suicide prevention, I knew that he was withdrawing, he was isolating. I didn't understand the term at the time, but self-medicating with drugs and alcohol. And who was I, his friend, to call him out on his use and his family issues in his school? But this was back in the mid-90s, and to be honest, this was the dark ages as far as suicide is concerned. Nobody talked about it. We didn't have a presentation, we didn't have counseling, we didn't have anything. It was just don't talk about it. Even my friends didn't ask me if I'm doing okay, and it would make me really frustrated because I thought if Jesse had died in a car accident or if Jesse had died of an illness, there would be an outpouring of support. But because of the manner of his death, there was no support. And so this went on for years with no conversations. And finally, my senior year of high school, my father is also a cop. And he asked me if I would be interested. He was on something called the Suicide Homicide Audit Committee. And what they were doing is they were going back and they were doing what's called a psychological autopsy of every youth who died, whether it was homicide, drug and alcohol overdose, suicide. And he had heard about something called the Yellow Ribbon Suicide Prevention Program. He said, hey, why don't you come down with me? I just want your thumbs up, thumbs down. Is this a good program? Should the police department get behind it? And first, right off the bat, I was excited because for the first time in my life, I heard the word prevention attached to the word suicide. Up until that point, we didn't really talk about suicide, and the only times we did is when it happened or somebody attempted suicide. Other than that, we just didn't talk about it. And so I went to the presentation, and I walked away just feeling really empowered, thinking, man, if someone had told me about the warning signs, the risk factors, if someone had told me there was a hotline, maybe I would have felt comfortable going to Jesse, or maybe Jesse would have felt comfortable going to me. And I walked away thinking, man, we gotta have this program in my high school. And so I went and I took a packet of information and a VHS tape. Do you guys ever heard of those? You guys know what VHS tape? All right. this whole thing makes me feel like I'm talking about an 8-track. So I went to my principal.
Thanks.
Yeah. Sorry, that was. You guys will get that joke later. We'll talk. So I went to my principal and I was like, hey, we need to have this program. We need to talk about this program. We need to be talking about suicide. Why aren't we talking about mental health? Why have I never heard the word suicide prevention uttered in this high school? And so it was the same principal that was there when Jesse died, and he said, look, you know, I think you're probably right, but give me the information and come back and see me tomorrow. So I came back the next day, and I walked into his office, and he kind of looked at me blankly, and he's like, why are you here? And I said, hey, remember all that information I gave you the other day? I want to start the program. And he said, you know, I got really busy yesterday. Come back tomorrow, we'll look through the information. So I came back the next day, same reaction. I haven't had time, I got busy. Why don't you come back tomorrow? And so every day for 3 months I came back, until finally one day I walked in his office, and I don't know if he was having a bad day or I caught him at the wrong time or the right time, but he said, look, Stan, I don't care what program you want to do. If you raise the money, we'll make it happen. And so I went, I raised the money, and the Yellow Ribbon program flew out the founders from Colorado who had lost their son to suicide. And this is how we used to do it back in the 90s. We'd have these really intimate personal conversations in the gym with 3,000 kids, and we'd talk about suicide. And so they were getting prepared to give their talk, and they looked at me and they said, hey Stan, have you thought about what you're going to say? And I just froze. I was like, wait, no, this is what I brought you guys out here, this is why I work, like I have nothing to say. And they're like, we think that your classmates would really like to hear from you. And you know, I just was struggling, and I thought, you know, I was in a writing seminar class, so I wrote a poem in memory of my friend Jesse. I'll read my poem and maybe talk about something, and we'll do that. And so now I'm sitting there in front of 3,000 of my classmates. Not only am I talking about suicide, but I'm reading freaking poetry to everybody. And I'm just mortified. Like, why did I do this? Why am I here? Like, this was a horrible idea. And I went home that night, and I just was like, this is the dumbest thing you've ever done. And the next day I walked onto campus, and I was walking onto campus. Our attendance lady had a window that faced the front of the campus, and as soon as she saw me, we made eye contact, and I saw her go out the back door, and she comes running out to me, and she has an envelope in her hand, and she says, and I remember these words very specifically, she says, I have a gift for you. And she hands me the envelope, and I open it up, and it's a letter from a girl named Sarah. No last name, no last initial. And in the letter she goes on to say that when she came to school yesterday, she was going to kill herself when she got home. That she just happened to show up on a day when we were having a conversation about suicide, and there I was, as mortified as I thought I was, reading poetry, expressing my pain and my loss of Jesse, and sharing hope for other individuals that are experiencing this pain. And she closes the letter by saying, you and I will probably never meet, but I wanted you to know that you saved my life. And I share this story with you because I want us, and especially you back there, to understand that I don't ever want you to underestimate the role that you can play. That when we speak about suicide, when we talk about mental health, when we share our pain, when we express hope about these issues, that there I was, a 17-year-old boy with no training in mental health, no background in suicide prevention, but simply because I was able to speak about it, because I was willing to show my own vulnerability and share my pain and express that, hey, there's always hope, I was able to save somebody's life. And I think one of the worst things that the field of suicide prevention has done for the last decade and a half is we've mystified it, and we've made it this power that only the special people can prevent suicide. And when you talk to the top clinicians and the top researchers in mental health or across the board in suicide prevention, they will tell you that the two factors that play a role in suicide are pain and hope, and that suicides happen when pain outweighs hope. And the best way that we can counter that is by connecting to other people. And connectedness is what keeps people alive. And for a long time in suicide prevention, we were focused so hard on convincing people not to die that we were missing the point. Because the point is not to convince someone not to die, it's to remind them of their reasons to live. Because when you focus on convincing somebody not to die, that sets the bar very low. And we just want you to survive. But when you talk about your reasons for living, you start to increase that hope. And there's nobody that has better access to our pain and our hope than our friends and our family members. And so one of the kind of lessons learned that I would want to share with this group is, yes, it's great if we get our clinicians involved, our law enforcement officers, our schools involved, But the most important thing we can do is remind the average person that they can be the individual that reminds somebody to stay. That gives them just a little bit of hope. That gives them just a little bit of hope that the pain is going to go away someday. And so, again, just don't ever estimate the role that you can play in suicide prevention. And I have a saying, and it goes that when you speak the name of the beast, it will retreat. That when you talk about suicide, when you make it a thing that we can talk about, then it becomes the thing that we can discuss, and it becomes the thing that we can work on. And one of the worst things that we've done in this society is we have made suicide a dirty little secret. That we have created a society that is so worried about liability and litigation that the instant that someone says the word suicide, we want to panic and press the red button, and that person needs to go to the hospital, and that person needs to go away. And we assume that if we can pass that person, then they'll pass him to somebody else, and eventually there will be this magic leprechaun that can cure suicide. And the reality is that every connection along that path is the opportunity to prevent suicide. From the school counselor who sits down with that individual and says, how, not just why are you thinking about suicide, but what is the pain all about? Where's this pain coming from? To the law enforcement officer that shows up at the school and says, okay, so I'm sorry you're having a hard time, but talk to me about it. To the intake nurse, to the psychiatrist and the psychologist, to the parents, to the people that come back and join that student. And this goes across the lifespan. Every person along that path is an opportunity to give that person just a little bit of hope. And I think when we whittle it down to pain and hope, it makes it more accessible to us, because we all have influence in pain and hope. We've all been asked questions about pain and about hope. And I think it puts us in a lot better place to understand that we can have an impact in suicide prevention. So I wanted to share that with you because I think it's an important lesson for us all to learn that this is not something that requires a specialized degree. Now, there are absolutely mental health professionals who are doing fantastic work around suicide and suicide prevention. But the reality is that the majority of mental health professionals will tell you that their training on suicide is limited to just assessing that individual. Should or should not this person go to the hospital? And we don't have enough mental health professionals out there that are willing to take on patients who are having thoughts of suicide and create an atmosphere where I can talk to my mental health professional about my thoughts of suicide and feel safe that they're not going to just put me in the hospital. Because if every time I say the word suicide, they put me in the hospital, I'm just going to stop saying the word suicide. And people learn these skills, and what we're also learning is that putting people in the hospital, if it's not an absolute need, can actually increase risk of suicide. And so we have to be very careful about the trauma that can ensue if we're inadvertently or over-accessing emergency departments for hospitalization around suicide. So I wanted to start with that story. I know that was kind of heavy. That was a lot to throw at you. Any questions so far, though? All right. Bill, you regretting that you brought me here already?
No.
Okay,
no,
good.
I have questions, but I want you to get into your
Okay, great.
presentation.
So, me and Bill have been talking over the last few months now. He's been talking to me about the formation of this council and kind of the goal of having a strategic plan. And so I definitely want to get to some of that. But before I get to that, I want to just kind of increase everybody's, I don't know, I want to say baseline knowledge around suicide. Because what I think we need to do is if we can increase the average competency around suicide prevention becomes not a big deal. And I'll quickly share another story with you. My best friend, he was the best man at my wedding. I've known the guy for years. He's the one person that I can go to with all my faults and weaknesses. About, I don't know, probably 10 years ago, we were next door roommates. We had 2 apartments right next to each other. And one day he came to me and he said, hey Stan, I'm going to move home. I want to move back in with my parents. And I thought maybe he lost his job or he broke up with his partner or whatever. And I was like, okay, whatever. And I asked him what was going on. And he's like, well, last night I thought about suicide. And instinctually, I wanted to reach across and wring his neck. I'm like, dude, this is what I do. I do suicide prevention. Why the heck wouldn't you call me? I'm your best friend. There's literally 8 inches of concrete separating us. Why didn't you call me last night? And then I took a breath and I realized that he knew that he was safe last night. And he also knew that when he told me today that I wasn't going to press the red button, that I was going to be able to talk about it like it's just a thing. It's a thing that we're going to talk about and we're going to figure out. And that's where we need to get to. We need to get to a place where the average person, the average mental health professional, the average EMT, the average cop can understand that suicide prevention or suicide is not just, I'm thinking about suicide and therefore I'm convinced 100% that I want to make a suicide attempt versus not having thoughts of suicide. And we put people in these buckets of low, medium, and high risk. And in the school setting especially, we go low risk or high risk. But I think when we do these buckets, we run into an issue because a low risk student to me is a student who's not thinking about suicide. Not a student who is thinking about suicide, just doesn't have a plan, and understanding that there's people who have thoughts of suicide and they go on for a few days or a few weeks or a few months, but they never get any further. And then there's people who have a very detailed plan, and this is how they're going to do it. They know the day, the music that's going to play in the background. And getting people to understand the spectrum that's there, but also empowering the individual. Because ultimately, as much as I believe in suicide is preventable, I don't believe that all suicides can be prevented. And that's a kind of a weird statement you would think coming from a guy who works in suicide prevention. But my hope with this work that I do is that I can empower the people around individuals and the individuals themselves to realize that help is available. That whatever the root of their pain is that there are things that we can do to reduce that pain and increase that hope. And we'll talk more about that. But with that, so I mentioned, so I'm actually, through 6 degrees of Kevin Bacon, an employee of Bill, because County Behavioral Health funds Cal Mesa. Through Cal Mesa, we have the Know the Signs campaign, which is a branch of Each Mind Matters. So Each Mind Matters is the overall mental health movement in California, symbolized by the lime green ribbon. For each of our major campaigns, we have a Spanish language version. So Sanamente is our Spanish language version of Each Mind Matters. For the Know the Signs campaign, we have an English and a Spanish version. You can get back and forth from either of these websites. I would encourage you to check out the website. I'm going to take you there after I'm done talking a little bit, just to introduce you to it. But the website's received really high evaluation scores. Really, it's there to educate people about the warning signs of suicide, what words to say, what questions to ask somebody when you're thinking about suicide, and then what are the resources and what can we do to empower people. But this quote here is my guiding principle when it comes to suicide prevention. That suicide prevention and intervention require constant vigilance. Because for about the first decade of my work in suicide prevention, I would go into a school, I would give an assembly with 2,000 to 3,000 students about suicide. Maybe or maybe not, I would train the staff. I would walk away and I'd say, I have just suicide prevented at high school. I'll come back in 3 years, I'll give another assembly, I'll give them a booster shot, I'll suicide prevent them again, and everything will be fine. And that's because I was young and arrogant and naive. And what I've realized is that in the school setting, in law enforcement, in emergency medical, and behavioral health, suicide prevention needs to be just something that we're constantly aware of, just something we're constantly thinking about, not just when suicide slaps us in the face. So, to give you a brief history of suicide prevention, the very first funding specifically for suicide prevention actually occurred back in the 60s. It was with the D.D. Hirsch Crisis Center down in Los Angeles. That was the first time we had a crisis call center established. Other than that, there were some nonprofits that jumped up along the way, some research being done, but not a lot of movement nationally. In 1999, the Surgeon General at the time declared suicide an epidemic. Now, we don't use that word anymore, and I'll explain that more in a minute. But him using that word epidemic was important because it forced the federal government to spend time and attention and money on suicide. 2 years later, we had the first national strategy for suicide prevention. That national strategy called on every state to implement their own strategy. In 2008, California became one of the first states in the nation to have a statewide suicide prevention plan. And then we'll be coming back to this in more detail, but in 2012, the national strategy was revised. And the reason why I wanted to share this with you is because I think for a long time, when we talked about suicide prevention, there was such a worry about liability or mistakes that people didn't want to admit the gaps that were there. But I wanted to point out that we've been, 1999, so 18 years ago, we've only been looking at one of the leading causes of non-natural death in our country for about 18 years. That's not a lot of time. If you look at the number of studies that have been done about heart disease, diabetes, or any of the other leading causes of death, it dwarfs in comparison to the number of studies and the research and funding that has been applied to suicide prevention. And I mention all of this because we're in a time right now where we have information, we have research, we have resources. It's not about pointing the finger and placing blame. It's just saying, hey, I don't know. And if if this coalition is going to be effective, you have to bring people in with the mentality that it's okay to say, I don't know, but I'm here to learn. Now is the time to change that conversation and get people to jump on board.
Can I just say something about that?
Yeah.
Because you're in Napa and we do a lot of cool stuff here. But back in 1983 in Napa County, we actually did a study on of just Napa County youth, because at that time we were seeing an increase in some suicidal behavior, not necessarily completed suicides, but some behavior. So we actually did, went back and took like a 2-year window and went back and re-interviewed all of those youth to try and gather information about what was going on with them at the time, what helped them, and
So
why.
youth who had attempted? And,
Yes,
okay,
yes, so
great.
these were all now youth who were still alive and doing much better. And you know, tried to get some information, because part of what we were trying to do was gather this information to talk about prevention. And so while I would love to say that was a huge success, what I will say is I think we got a lot of good data, but honestly, even in wonderful Napa, where we do a lot of progressive things, we could not get a lot of people to take that next step. Like, look at this great information we have, look at what we can say about prevention. But you're right, prevention was not something anybody else wanted to talk about.
Well, and I'm willing to bet that 90% of the presentations that are being done right now have the same information: warning signs, risk factors. You know, we need to figure out what are the other ways, and that's why I bring up the conversation about pain and hope, because I think that starts to change the conversation. Because when I'm talking to somebody about suicide, once I know that they're having thoughts of suicide, whether or not they have a plan, and some other questions around assessment, my conversation immediately goes to what's the pain, you know, understanding the pain. So, but thank you, that's great to hear. So I want to talk just for a second about terminology, because one of the things, another key focus of mine, aside from strategic planning around suicide, is messaging around suicide. So I'm on the American Association of Suicidology's media and communications team. I'm the media representative of the San Diego County Suicide Prevention Council. But what we need to understand is the ways that we message around suicide greatly impact public perceptions around suicide. So we're going to talk about terminology first. So when someone dies by suicide, what's the most common phrase that we use? That person is what? They have committed suicide, right? Okay, so let's play a word association game. What are some of the other actions that we commit? We commit murder, we commit crime, we commit, the third is always adultery. That's what people always say, adultery.
I was going to say sins, but
sins,
like after school
also,
upbringing.
adultery is not a crime, but it is a sin. We commit treason, we commit larceny, arson, a bunch of negative things. Now, that's where our minds go. But you also could have said, I committed to my marriage, I commit to my friendships, I commit to my job, I commit to showing up at school every day. We commit to a lot of positive things, but the term commit, especially the term committed, immediately takes us in a negative place, because most religions, most faith institutions still view suicide as a sin. They are starting to change that conversation, because they're starting to realize that if they want their people to come to their leadership, to their guidance counselors, that they may not go there if what they're thinking about is a sin, and so we need to change that conversation. A lot of people don't realize that attempting suicide used to be illegal up until about 30, 40 years ago in every state across our country. And again, what that does is it creates barriers to people asking for help. So rather than using the term committed, we ask that people use the term died by suicide or took their own life. Another one you might hear is died of suicide. There's a term that it's kind of going back and forth. I don't get too hung up on this one, but you'll hear people say completed suicide, and people will say that you shouldn't use completed suicide, because when you complete something, it's a sign of success. So again, I don't get too hung up on that one. And honestly, I don't get too hung up on this one, because it's just so ingrained in our society. The one that I find more egregious is this down here, successful versus unsuccessful. Because if you successfully attempt suicide, you're alive or dead. You're dead, right? If you were unsuccessful, you're alive or dead. You're alive. So if you succeed, you die, and if you fail, you live. Pretty backwards way to talk about it, right? So rather than those terms over here, it's simply a death by suicide and it's attempted suicide. And when we use those terms, what we do is we remove the ability to bias and throw in any coloring of opinions around the terms. It's either a death by suicide or it's attempted suicide. It's not focusing on crime, sin, guilt, blame, or anything. And the more clear, and you're going to catch yourself 1,000 times before you get it correctly, but just one of the filters that anybody in this room and anybody that you work with, it's a very simple step to just engage people around this topic. And once you start to engage them around terminology around suicide, it's a lot easier for them to understand that suicide prevention can be accessible, and there are things that we can do to prevent suicide. So now I want to talk about messaging. When it comes to suicide, there's two effects that we look at when it comes to messaging. A lot of research has been done about these, and we're starting to realize that they really shape public perceptions and public outcomes around suicide. One is called the Virtue effect, and one is called the Papageno effect. And I'm going to start with the Virtue effect. So the Virtue effect is based on a book called The Trials of Young Virtue. It was a novel that was circulated around Germany in the 1800s. And the main character in the novel is a young man in his 20s, and he ends up dying by suicide. And as that book circulated through Germany and then through the rest of Europe, what they found is there was a lot of men a lot of young men who read the book and exposed to the book who were dying by suicide. And so they actually banned the book and they pulled it from shelves. And what we found is this carried over into the modern day. And so the term was coined by a sociologist. We saw this when Marilyn Monroe died. When Marilyn Monroe died, there was so much coverage around the way she died and the manner of her death, that there was a 200% increase in young females that kind of identified with her. And so we've seen that carry on today. We were really worried that that was going to carry on when Kurt Cobain died by suicide or Robin Williams died by suicide. But that's when we started to look at what's called the Papageno effect. That if you counter a negative situation with positive messaging that includes resources about suicide prevention, education about warning signs and risk factors, where to go, what to do, what to say, that you can actually increase help-seeking behavior. So when Robin Williams died, instead of seeing an increase in suicides, what we saw was a 500% increase to the National Suicide Prevention Lifeline. We saw a 200% increase to the Know the Signs that Suicide is Preventable.org website. And so if we have positive messaging around suicide, we can steer those vulnerable individuals towards help seeking instead of closer. A couple other things we want to do is we don't want to oversimplify the causes of suicide, and we don't want to make suicide seem like it's something that's common. So I'm going to use this as a demonstration. 22 veterans a day die by suicide. Aside from the word commit, what if I were that veteran walking down the hallway and I saw that poster that said 22 veterans die by suicide today, and I'm having thoughts of suicide? If I were to get that message from that poster that says 22 people just like you are going to die today, what it might inadvertently do to me is it might normalize suicide. It might make suicide seem like something that is common or acceptable for people in my circumstances. So it's kind of putting everybody in this bucket. Another thing is that the data simply isn't accurate. It's not literally 22 veterans every day who are dying by suicide. Somebody took the number of veterans who die every year by suicide, they divided it by the number of days, and they came out with the statistic 22 veterans a day die by suicide. Now this was a great call to action and call to arms. It gave people, it enraged the public, and it made them go to their politicians and say, hey, we need to be doing more for the VA. The problem with it is that this number of 22 is so ingrained in our society now that we don't realize that the number's actually gone down. It's now 20 veterans a day who are dying by suicide. But what this statement does is it not only oversimplifies the causes of suicide and says, well, if you're a veteran, you're more likely to die by suicide. One of the things, and I love the Trevor Project and the work that they do, but one of the worst things that they ever put out into the world is that LGBTQ youth are 3 to 4 times more likely to attempt suicide. Nobody, I don't care who you are, nobody wants to assume that just because of one aspect of you, does that automatically put you in this bucket and identify you with everybody else. And so it's a very dangerous message to say to somebody, to walk into a room and say, oh, just because of part of you, you are more likely to die by suicide. Now, the other issue that it comes along with is it doesn't give enough complexity. It's not being LGBTQ that makes you more likely to attempt suicide. It's the discrimination and the prejudice faced by society. So it's not the individual's problem, it's our society's problem. It's the discrimination and prejudice that comes from that. So it's pointing the finger in the wrong direction. So we just want to be very careful about the messages that we use and how we frame those messages. And there's a website, and I would encourage all of you to spend some time on it, suicidepreventionmessaging.org. It's created by the National Action Alliance, which is the guiding entity behind the National Suicide Prevention Strategy. But really simply, just 2 simple questions. What are the messages that we're using, and what are the messages that we're sending? Who is our target audience? What are we trying to get them to do? Because unfortunately, a lot of times when it comes to suicide, we use scare tactics, and we think, We need to tell people how often this happens. We need to scare them. We need to tell them how lethal it is to use a gun versus it is to use pills. And we need to scare people. But what we know is that simply doesn't work, and that actually increases risk of suicide. I would also encourage you, don't assume that the people that work in my field know what the heck they're talking about. Because you can go to websites from suicide prevention organizations and you'll hear statements that suicide is 100% preventable, or that this individual is 3 to 4 times more likely to attempt suicide. So filter it through and realize that you have the competence to realize, is this an appropriate message for the audience that we're sending? Now, if I'm going to a politician or the board of supervisors and I'm trying to get funding for LGBTQ programs, yeah, I will tell them that LGBTQ youth are 3 to 4 times more likely to attempt suicide because it helps get me what I need, which is the funding. Or I'll tell them 22 veterans a day died by suicide. But if I'm going to veterans, LGBTQ youth, I won't use those statements because I don't want to inadvertently increase risk of suicide. Any questions about messaging? That was a very quick crash course in messaging.
Yeah, so it had been on my mind because, you know, as I prepared for this, I'm struck by the fact that in little Napa County, on average, 2 people a month die of suicide. And you wouldn't know. And I have wondered about that, right? So I'm aware of the contagion effect. I'm aware of the unintended consequences of poor messaging. But I also find myself wondering, what's the impact of never talking? This not being common knowledge or a part of our, you know, community discussions.
Yeah, and I would, rather than frame it, so when I use those statistics, I would put it on a yearly basis rather than a monthly basis. Because again, when you say 2 a month, it's not actually 2 a month. It's take the number on average every year. This many people are dying by suicide. And we have to walk, it's a very careful line that we have to walk because we want to make people aware. We want to cry to the public and say, hey, you need to focus. There's a fire over here. Help me put out this fire. And yet you don't want to increase that risk. So one of the ways that you can do that is if you're going to share statistics about the, you know, any one of us would agree that 1 suicide is too many. But if you're going to, you know, share statistics to try to get people engaged and get them outraged about how many suicides are happening, just make sure that you're including that information on the resources, the warning signs and risk factors. Like when you see, you know, when I read the paper about, you know, or I mean, in America, name one of the viruses that has passed through. The Zika virus, bird flu, this, that, the other thing. Within 24 hours, everybody in America knew what hotline to cover, what were the warning signs, what were the risk factors, and it was just in our reporting that if we talk about a public health issue, we need to include hotlines, we need to include information about how to prevent it. So you just want to make sure that there's that prevention messaging alongside it. One of the other things that I would do too is that it's not just the people who are dying that is the issue, it's the people who are thinking about and attempting suicide, and that becomes a much greater number. For every 1 youth who dies by suicide, there's estimated that there's 200 other youth who attempt suicide. For every 1 adult who dies, it's estimated that there's 25 other adults. And so we also need to frame it that it's not just the deaths we're trying to prevent, it's the suffering that we're trying to prevent. When we think about, I think it's about, I don't want to misquote the number, but hundreds of millions of people last year attempted suicide in America. And those numbers should outrage us, but we don't talk about that. We still focus so much on the death. But I guess the short answer is if we have to be able to walk that line to get that public engaged, but if we're going to do it, we need to make sure we're also not creating more of a problem and putting that prevention messaging in there. Great question. Any other questions? How's the psychology class going on back there? You guys glad you came, or are you looking for the door? All right, so hopefully did everybody grab handouts on their way in? Students in the back? You guys got handouts? Sure, please. Sure, please. No, I'm gonna go bust your chops. It's all right, I'll interrupt my presentation and give you guys your homework. That was a close-up shot. Sorry about that. So the PowerPoint is just the slides from today, and then the other one is what I did last night when I got in on the airplane. Is I realized I just wanted to give you a summary document because the National Strategy for Suicide Prevention looks like this. It looks like a college textbook, and I would encourage you to read it, but realistically, none of you have the time to read it because you're very busy people. So I took the time to just summarize it. And so what you'll see are the first kind of 2.5 pages of it outline the 4 strategic directions and then the various goals underneath that direction. Each of those goals has various objectives that kind of solidify it. And then the last 2 pages of it talk about what you can do. And so the national strategy actually identified steps that the government, the federal government can take, steps that state and county agencies can take, steps that businesses can take. And so I kind of consolidated all those. And so we'll be going through that in just a little bit, but wanted to explain what that document is. But really quickly, just a quick overview. The national strategy is separated into kind of 4 key areas. So there's healthy and empowered individuals, families, communities, clinical and community preventative services, treatment and support services. And Bill, I know you're big on data, and so you'll be pleased to know that data is right here at the middle, because we need to have data and surveillance around every single one of these efforts so we know what's working. We need the data to inform. One of the strangest things that I see in suicide prevention is that if you look at the number of suicide prevention programs, there's probably 300 that have been created, and probably 275 of them are youth suicide prevention programs. In reality, youth die by suicide less than any other age group, and yet we spend more money and more time and more effort trying to prevent youth suicide. Now, part of that is because we see the highest incidence of suicide attempts in that youth age group, but the highest group that's dying by suicide is middle class, middle-aged white males. But that's not a very sexy group to target. It's not easy to go into a group and say, hey, we need more funding for middle-class white males. Because as that group, they've been the group that's been taking the funding from everybody else, so why would we give funding to that group? But that's the group. If you wanted to target one group and have the single biggest impact on suicide, you would target middle-aged white males. So I'm going to run through the goals. So these are goals 1 through 13 that are listed with the objectives underneath them. So strategic direction 1, healthy and empowered individuals integrate and coordinate suicide prevention activities across multiple sectors. That's exactly what this entity is trying to do with that plan. Implement research-informed communication, increase knowledge of the factors that offer protection from suicide behaviors, and promote responsible reporting of suicide. Now, when it comes to suicide, there's typically 2 buckets that we talk about. We talk about warning signs, which are behaviors, and we talk about risk factors, which are situations in a person's life that can increase risk of suicide. One of the areas that gets most often neglected is protective factors, because you can have 2 people that have the same warning signs, the same risk factors, but what really differentiates them is the protective factors. If someone has a strong therapeutic relationship, a strong family network, that person is much less likely to die by suicide. And I don't think we give enough, enough power, enough balance to protective factors in people's lives. Strategic direction 2, clinical and community preventive services. Develop, implement, and monitor effective programs that promote wellness, promote efforts to reduce access to lethal means. Reducing access to lethal means has been proven to be the single most effective strategy for suicide prevention. And this goes counter to many people's beliefs, because for a long time people said, well, if you take away the gun, they're going to get the pills. If you take away the pills, they're going to get a rope. If you take away the rope, they're going to go to a bridge. If you put up a barrier, they're going to find some other way. But suicides don't just happen by people who have thoughts of suicide. They happen by people who are capable of following through with those thoughts. And you can talk to people. In my life, I've struggled with depression and had thoughts of suicide. And what I can tell you is that even through the year that I would say that I was suicidal, there was probably only 2 or 3 times that I was really capable of following through with those thoughts of suicide. And so it's about creating speed bumps between a person's thoughts and them following through with the suicide attempt. And I'll give you a few examples. So in Great Britain, what they found was that there was a certain medication that was being used in a high number of suicides. And so what they did is they changed the prescription, they changed the packaging. And by changing the prescription, what I mean is that instead of being a 3-week prescription, they made it a 3-month, or instead of being a 3-month prescription, they reduced it down to 3 weeks. And so what that meant is that every 3 weeks, that individual who was taking that medication had to be seen by a medical professional. We don't always think of pharmacists as medical professionals, but they are. And actually at UCSD, we're training every pharmacist who graduates with a doctorate in pharmacy is being trained in suicide prevention, because they are giving the means and methods right across the counter. The other step that they did is they changed the packaging. So rather than being a bottle of pills, they made it a blister pack, which are those aluminum foil packs where you have to pop out each pill. It sounds very oversimplified, but how many actions does it take to attempt suicide using pills in a bottle? You unscrew the cap, you pour them, you swallow them. 3 actions, right? How many actions does it take to attempt suicide using 100 pills in a blister pack? 100 individual actions. Now, that's not necessarily a time barrier or a physical barrier, but what that does is it forces me, instead of just 3 very quick impulsive actions towards a suicide attempt, now I have to take 100 deliberate actions towards a suicide attempt. That's 100 opportunities for me to realize, wait, what the heck am I doing? What's going on? And what they found is what they expected, is that suicides using that medication went down. More importantly, suicides overall went down. So it went against this idea that if you take away this, you're going to go do that, because they didn't even switch to a different medication. The suicides just went down. This was replicated in China and India when they reduced the toxicity levels of the gas in the home. Suicides again went down. And even in more practical terms, a colleague of mine was working with a military veteran who had expressed thoughts of suicide and simply would not allow the firearm to be taken from his home. And so she asked him, and she said, well, where do you keep the gun? He said, I keep it in my nightstand. And she said, well, obviously last time you were going to attempt suicide, something stopped you because you're still here. What was it? And he said, it was my daughter. I thought about my teenage daughter. She's my whole world. And I thought about what this would do to her. And she said, this is what I want you to do when you get home. As soon as you get home, I want you to take your favorite picture of your daughter, and I want you to open that nightstand drawer, and I want you to put that picture on top of the gun. So that if you ever go to reach for that gun in a suicide attempt, you physically have to move your daughter out of the way. And he said that even that act alone saved his life at least 5 times. So suicide prevention, one of my favorite quotes is that we can't wait for perfect. We can't wait for all the research. We can't wait for all the perfect things. Sometimes we just have to figure out in that situation what is the best thing we can do. But I bring up this access to lethal means because the conversation about primary care, that is something that we need to be counseling more medical professionals about, is just asking questions about access to lethal means in the home and what are the alternatives to get the firearm out of the home or the other medications and other means out of the home. So providing training to community and clinical staff. Direction 3, treatment and support services. Providing suicide prevention is a core component of health care services. Promote and implement effective clinical and professional practices for assessing and treating those identified at meet or risk for suicide. Provide care and support to individuals affected by suicide deaths. I just want to talk about assessment for just a moment. So, is anybody here familiar with the Columbia Suicide Severity Rating Scale? A couple of us, great. Well, this is something that I know we've talked about in our calls, but one of the key strategies that I've seen other counties implement is trying to get everybody to adopt the Columbia Suicide Severity Rating Scale. And I'll speak to that for just a minute, but basically there's a variety. There's 100 different suicide risk assessment tools that can be used. But the benefit of having everybody using the same one is that that means that, just using a school setting as an example, is that if the counselor is using the same assessment tool as the EMT is using the same assessment tool as the cop is using the same assessment tool as the intake nurse is using the same assessment tool as the psychiatrist is using the same assessment tool as the outpatient therapy that they're going to be referred to. It means that everybody is speaking the same language. It means that everybody's on the same page. And so just uniformly adopting a suicide risk assessment tool is key. Another issue that I see around risk assessment is those AB 2246 trainings that I've been conducting. I mentioned I've done about 20 of them, probably representing, 300 districts around the state. Of all the districts that I've asked, I've only had 2 districts raise their hand when I say, is every school within your district using the same suicide risk assessment tool? In many schools, each counselor is using a different tool, each school is using a different tool. When you ask them, why are you using that tool? They say, I don't know. This is just the tool that we use. Well, who created it? I don't know. It's just the one that was here when I got here. And so if we're trying to reduce liability and give effective care, let's figure out why we're using that tool. And that assessment tool, the Columbia Suicide Severity Rating Scale, has got more research and more support for it than any other tool that's been out there. The best part about it, though, is it gets beyond the simple questions of, are you having thoughts, do you have a plan, and asks about, have you taken any steps towards following through with this plan. And then number 4 is about surveillance and data. Increase the timeliness and usefulness of data. So one of the conversations within this group I would hope would be, how do we get our information as timely as possible? Hopefully every 6 months, but by the end of the year, by the end of 2018, we should hopefully have all the data for 2017. And then promote research on suicide prevention, evaluate the impact and effectiveness of suicide prevention interventions and programs. So in your handout again, just to show you, so I just went through the 13 goals that are highlighted. And again, you'll notice under each of those goals there are specific objectives that are identified to explain those goals. Those strategies that are at the last 2 pages are identified by the goal that they represent or the objective that they represent. So you'll start to see that there's somewhat of a roadmap. And I know I'm covering a lot of information tonight, and I'm going to cover a few more key documents that are out there. But really what the point that I'm trying to get across is that you're not flying blind out there. There are very strong resources that are supported by evidence and best practices and research that can inform the steps that this group is going to take to implement suicide prevention strategies. What I also wanted to get across in my time with you tonight is just to give you some baseline knowledge about resources that are out there. So one of the best resources you have at your disposal is the Suicide Prevention Resource Center, sprc.org. They have a best practice registry of programs. They create a number of fantastic documents, and they actually have what's called an academy on strategic suicide prevention. It's like a 3-video kind of tutorial, online tutorial that I would encourage everybody here to participate in. But on these next few slides, they identify a few key pieces. So the comprehensive approach to suicide, they identify it as having 7 key pieces. Identify and assist, increase help seeking, respond to crisis, post-vention, reducing access to lethal means, life skills resilience, effective care and treatment, care transitions and linkages, and that keyword that I shared with you earlier, connectedness. When it comes to strategic planning, this is kind of that overarching just strategy for that. Describe the problem, look at long-term goals, look at the key risk and protective factors that you can reduce those risk factors, increase those protective factors, select or develop the interventions, plan the evaluation, and then implement, evaluate, and figure out what we can do better next time. And then the keys to success, one thing I would really encourage this group to start looking at is including people with lived experience, including loss survivors, which I think you mentioned are some of the folks that had the flu tonight, but also exploring what groups out there have access to people with lived experience around attempt survivals. That is a group that has been long neglected, and it's a group that we're finally starting to pay attention to more and more and giving them the respect that they deserve. It's all about partnerships and collaboration. Just seeing the variety of people that are in this room or who are typically in this room, continue to bring people in. When you bring in one school district, you're more likely to get a second school district. By bringing in one law enforcement agency, you're likely to get a second. That safe messaging around suicide has to be consistent in everything that you do. We need to be culturally competent. One thing that my field is kind of a little embarrassed to admit, but I'll admit it even though I'm approaching the middle age and I am a white male, is that suicide prevention was created by middle-aged white males. It is very white-dominated, very straight-laced dominated, and we need to be exploring and looking for programs that don't fit that mold. When you go to the American Association of Suicidology Conference, you will see 300 white males and older white females in a room talking about how we should do suicide prevention planning for the country. And we need to be more culturally competent. We need to be looking at other programs and other resources. Because one thing that we always hitch our hats to is evidence-based. But if a program is evidence-based in rural Minnesota, does that mean that it's going to be effective in Compton, Los Angeles? Not necessarily. So we need to be willing to take a chance on programs that are not necessarily evidence-based and be willing to make mistakes. Any questions? I hope I didn't offend the entire room with that conversation, but
Just the white guy.
just the white guy. Just the middle-aged white guys? Yeah.
And the older women.
So it is this half of it.
Yeah.
I'm going to stand over here then. But any questions, any comments, any thoughts?
So, when I think of, the next step for us is in addition to outlining what is a broad plan, what are some of the activities we want to develop now, things we want to do now? And the ones that stand out to me are, how do we begin the messaging in the community so that folks know what questions to ask and what signs to look for? And when you talk about doing it safely and the consequences of doing it unintentionally poorly, that worries me. So, do you have any direction or guidance about how to move in this direction well?
Well, fortunately, I mean, you have an entire social marketing campaign at your disposal through the Know the Signs campaign. Every one of those is based on safe messaging. You have materials, you have brochures, coasters, posters, a variety of information in a variety of languages that are all vetted through the safe messaging spectrum. We also do, every year for suicide prevention, we do a toolkit that has email blasts and social media templates. So I think right there you're off to a good start because you have access to all those resources. You have access to me and my team. So I think right there, don't think that you need to go out and reinvent the wheel. I think another part of it is that it's not just suicide prevention messaging, as you kind of heard in the goals and the objectives, is that it's also mental health messaging. So mental health is suicide prevention. Substance abuse reduction is suicide prevention because there's so much connection and correlation between the two. So if you're going to be jumping into the community, to be honest, I would probably start with mental health. I would probably warm them up to the idea and get them to understand that mental health is more than mental illness, and then work your way into suicide. Actually, I was gonna, never mind, I'm gonna make an inappropriate joke, but I'm not going to because Bill asked me to be here and he asked nicely. Now I'm gonna ask you, young adults in the back of the room, how many of you have heard Logic's song, 800-273-8255, right? Okay, so, anybody else heard of that song? Got one nod?
Yeah. You guys have heard it, you just don't realize it.
Yeah, so for years and years and years, I've been giving my friends posters, brochures, t-shirts with the National Suicide Prevention Lifeline. Logic is a hip hop artist. He came out with a song about 3-4 months ago. The title of the song is 800-273-8255. He performed it at the American Music Awards and the VMA Awards. Within 3.5 minutes, he educated about 50 million youth and young adults on the National Suicide Prevention Lifeline. In 3 minutes, that guy did what we haven't been able to do in 20, 30 years of promoting the National Suicide Prevention Lifeline. So sometimes we also have to be creative in the avenues. I've been doing a lot of work with the radio station, Power 106 in Los Angeles. They're utilizing that song for their public health awareness efforts. Sometimes we have to be a little bit more creative and go a little bit more outside of our boundaries of, well, let's go hang posters in coffee shops and bathrooms. So I'd be happy to also talk with you about what does that marketing strategy look like and how do we get to those folks, how do we reach these individuals. So just wanted to mention that there's some creative, effective ways to do it.
I've noticed throughout my career in mental health and in primary care that one of the main difficulties or barriers are people are really afraid to ask the question.
Yeah.
What, the tools that you're talking about and from your experience, what is the best way to train or have people sensitized to their not so afraid?
I think it's what they call Gatekeeper training. So there's a variety of them. QPR, question, persuade, refer, safe talk, suicide talk. There's a number of programs out there. I would say predominantly across California, most counties are adopting QPRs. They're Gatekeeper training because of the time frame. It's a 1-hour training. Safe Talk covers about the same amount of information, but it's a 3-hour training. And the reality is, it's just, especially in like a school setting, for example, you're not going to be able to send people to a 3-hour training if you can send them to a 1-hour training. So getting people engaged on those, getting those Gatekeeper trainings, and really, when I'm doing the AB 2246 trainings, what I tell folks is like, yeah, it would be easier to do an online version of the training and have people click through a couple slides. That's only going to educate people. You really need to get someone warm in the room to raise the comfort, because it's not just about educating people, because they can go to the Know the Signs website, they can learn about it. It's about raising the comfort, because it's scary to ask that question. When I do trainings, I'm a QPR master trainer, and I kind of throw away a few of their slides because I simplify it and I say there's 3 questions I want you to remember. Are you thinking about suicide? Do you have a plan? And then asking about the pain. How bad does it hurt? Scale of 1 to 10, what does it take to do better? But getting people to, in those trainings, make sure that there's a role play scenario where people are actually asking the question, are you thinking about suicide? Because I work with crisis negotiation teams, these big, bad, burly dudes, they're ex-special forces that are on the SWAT team, and they'll go up on a bridge with somebody who's obviously thinking about suicide, and they'll go up to them and they'll say, hey, are you thinking about hurting yourself? And I'll hey guys, come over here. Why didn't you ask them about suicide? They're like, well, we don't want to put the idea in their head. I'm like, dude, there's a helicopter, a fire truck, and a freaking SWAT team. You can say suicide. They're obviously here for suicide. But I share that story with you, and I share this in my trainings because it is a normal human reaction to be completely terrified of that question. And I'll do a practice scenario where I have people ask the question, and then instead of doing a role play, I'll tell the other person. So person A is asking the questions. I'll tell person B not to say anything. Don't respond. Don't say yes or no. And it gives that person that opportunity to ask the question without the fear of, what if they say yes? What if they say yes? Because that, getting people to get used to the blood pressure. I don't know if anybody ever served in the military, but it's called, they have live fire exercises where you get used to the adrenaline rush and the palms sweaty and the blood pressure going up so that you can be prepared to realize that, yes, I'm nervous, yes, I'm scared, but I still have a job to do. So rolling out Gatekeeper trainings through primary care, even through behavioral health, through healthcare settings, through law enforcement, through EMS, but also into the community, getting into the schools and educating teachers about how to ask that question. Getting parents, getting friends, just getting the average person, because that's really, as much as we want to say it's professionals who are preventing suicide, suicide gets prevented on couches and at dinner tables. So identifying a solid Gatekeeper training and having a really strong group of trainers who can go out into the community, whether that's volunteer-based, whether you're pulling people from organizations, or whether that's stipend-based, but having a strong presentation group is one of the key ways to get people comfortable asking that question.
Thank you.
Yeah, of course. Any other questions? I'm just going to breeze through the rest of the slides because I'd rather us have a discussion than just me up here talking for the rest of the time. I just want to share these, and I'll, Bill, if it's all right with you, I'll put together a follow-up email with links to everything and PDF versions of everything. But this is kind of a follow-up document to the national strategies. The national strategy is kind of big picture. This transforming communities kind of whittles it down to the community level. But again, you'll see those same consistent themes: unity, planning, integration, fit, communication, data, and sustainability. One of the things that I would really look for with this group is really focus on sustainability. And that's why I think it's so important to have a strategic plan that's guiding your efforts. Because one of the weaknesses that I see around the state is that, for those of you not familiar with county behavioral health or MHSA funding, is that there's Mental Health Services Act funding, and a part of that is called Prevention Early Intervention funding, which is a lot of things around mental health awareness, stigma reduction, and then typically most counties have a few bullet points that relate to suicide prevention. The problem is when all of the suicide prevention efforts in a county are housed within this plan, if the funding changes, if the politics change, those bullet points get switched out and swapped around. But by having a strategic plan that is embraced by Aldea, by county behavioral health, by healthcare agencies, by EMS, by law enforcement, you now have a plan that everybody is committed to regardless. And outside, now a lot of the work, a lot of the funding may come from behavioral health, but having a standalone plan is the key part to creating that sustainability, so that, hey, we're going to have a suicide prevention plan even if all the MHSA funding goes away. So just something to think about. Another resource to add on to it, and I promise that last one was a pretty quick read. This one's an even quicker read. This is from the CDC, and this is a technical package. But what it does is it gets into very specific recommendations. So it gives you a strategy, for example, strengthen economic supports. Approaches, strengthen household financial security, housing stabilization policies. So these typically you wouldn't classify these as suicide prevention efforts, and yet they very much are suicide prevention efforts as long as they're coordinated and fit into that training. So identifying and supporting people at risk, those Gatekeeper trainings we just talked about, crisis intervention and treatment for people. I would say that one thing that I would encourage you to look at that I feel is a gap in most counties is that, yeah, we can always improve crisis services and follow-up, but the biggest gap is what to do with the people in the middle, the people that don't need to be hospitalized, but we need some sort of care for. What does that look like in this community? What is that crisis stabilization, or what is that kind of middle-of-the-road resource for people to go get stabilized, get connected to outpatient therapy? And then this is just a quick view. This is based off the San Diego County Suicide Prevention Plan, so we have kind of universal selected indicated strategies. I just wanted to have you to have an example of that. So with that, I'm just going to sit down and we can just talk for a little bit and see. I hope that's kind of what you were.
Yeah. Yes, yes, it was. And that, by the way, is the framework that we're proposing we fill in and use to structure our strategic planning process. So